Good evening. It's a very pleasant task to cite Professor Hemantha Dodampahala, who is my friend, who have been a friend for last so many years, I suppose from his medical student days. Professor Hemantha Dodampahala was born in 3rd September 1965 at Gampaha Base Hospital. His father was an assistant superintendent of police and the mother was a loving, caring housewife. He was the penultimate, that is the one before the last, of the family of 5 children who are currently leading in their professions worldwide. He started education at Dharmaraja College, Kandy, then moved to Isipatana College, Colombo, and passed his A-levels from Bandaranaike College, Gampaha. He entered Colombo Medical Faculty in 1986 and he passed all his exams with second-class honors. At the final MBBS, he obtained the awards for obstetrics and gynecology and was placed 14th in the position of the Island Merit. Soon after his internship at Professorial Unit in Colombo, in 1995, where he currently works and has passed his Master of Surgery, Obstetrics and Gynecology, received his registrar training at Professorial Unit Peradeniya under Professor D.A Ranasinghe. His senior registrar training was under the guidance of Dr. M.D.P. Gunaratna. He was introduced to Professor Phil Baker by Professor D.A Ranasinghe. While working in UK, he had made his maiden treasure in research by publishing 3 index second author publications regarding fetal MRI. He has passed his FRCS in 2001 and became a Fellow of Royal College of Surgeons, Edinburgh. Soon after, he obtained the membership of Royal College of Obstetricians and Gynaecologists upon completing the second 2.5 years of overseas training. He returned to Sri Lanka in 2002 and received board certification with effect from 1999. Upon achieving his board certification, he was posted to work as a consultant obstetrician and gynecologist at Horana Base Hospital, Balapitiya Base Hospital. He was very active in directing maternal services during tsunami time at Balapitiya. With his outstanding qualification, teaching abilities and research, he was appointed as a senior lecturer in fetal medicine attached to Faculty of Medicine, University of Colombo. He currently a professor in obstetrics and gynecology at the faculty and honorary consultant to Disoisa Maternity Hospital, National Hospital of Sri Lanka. He also serves as a senior superintendent of police attached to Police Hospital. His special interests are in fetal medicine, maternal medicine, high-risk obstetrics and subfertility management. In addition to his fetal medicine publication, he is an author of gynecological endocrinology. He is a skilled ultrasonographer who has introduced invasive fetal procedures and 3D, 4D ultrasound scanning to Sri Lanka. He has performed fetal intrauterine transfusion, fetal vesico-amniotic stenting, and numerous invasive fetal procedures. His current interests are morbidly adherent placenta management, pregnancy-induced hypertension, fetal abnormalities and fetal hypoxia, and finally it's about subfertility. He is a very skilled surgeon and all-rounder in the field of obstetrics and gynecology. He is a very skilled guitar player and loves music. He has over 100 publications with over 500 citations, 50,000 reads and over 25,000 views on his research and educational videos. He has conducted many activities to the college and held the Office of Global Relationships, Continuous Professional Development. He is also a Fellow of International Society of Ultrasounds in Obstetrics and Gynecology, Fellow and current Chairman of Academic Activities of SLCOG and the President-elect and waiting to be the President at 2023. Recognizing his research abilities, His Excellency the President has appointed him as the Chairman of the National Research Council of Sri Lanka. He is currently a research fellow appointed by Southern Cross University and Australian Institute of Cardiology, Queensland. He is a RCOG representative appointed by the Royal College of Obstetricians and Gynecologists for the Representative Committee, continuously serving up to date. Let me invite Professor Senani Hemantha Dodampahala for his delivery of D.A Ranasinghe Oration. Thank you. I have to give the medal. Before starting the oration, let me present Professor Dodampahala with the Orator's Medal.
Thank you very much, President Sir. Evolving Paradigms and Perspectives of Fetal Hypoxia, Today Oration, is in tribute to one of our great personalities in obstetrics and gynecology, that is Professor Don Abraham Ranasinghe, who was born in 26th of December 1908 in a quiet village of Velangana. His father was a well-known notary public of the area. He entered the Ananda College at the age of 8 years. At Ananda, he excelled not only in academic pursuit but also in cricket, soccer and tennis. In 1930, he entered the Ceylon Medical College and spent his many happy years passing out in 36 with first-class honors. It was a time that he got married to Beatrice Samaranayaka and started a family. 3 children were born to them from 1939 to 1943. When their 4th child was about to be born, Dr. Ranasinghe had to leave for England for postgraduate studies. Soon after he settled down in London, he received the sad news that his wife has died at the childbirth. Despite his personal tragedy, he continued his work, and in 1949, he married Anne, a very attractive nurse, staff nurse from the hospital, and had 4 children born to that marriage in the next few years. He obtained the membership of Royal College of Obstetricians and Gynecologists in 1949 and fellowship from the Royal College of Surgeons, England, soon after. On his return back home, he was appointed a senior lecturer in obstetrics and gynecology to Sir Nicholas Artigala, then who was the professor at that time. After the retirement of the Sir Nicholas, Professor D.A Ranasinghe was appointed as the chair in obstetrics and gynecology, a post he held till his retirement in 1974. It was during this time he excelled as a teacher, as an astute clinician and a renowned trainer. He held many prestigious positions in professional organization. He was instrumental in starting our college, and he was the first founder president in 1968. He became the patron of the college in 1970 and held his position until his death in 1981. He was the president of the Family Planning Association for 18 years. He took keen interest in the medical students and student welfare. He was a warden, and he used his personal funds to look after the well-being of the student. And there are 3 scholarships in the name of his parents, using his own money. On his retirement from the Chair of Obstetrics and Gynaecology in 1976, the university honored his work by awarding the Emeritus Professorship. In 1979, he was appointed as the Vice Chancellor of the University of Colombo, and 1980, he was honored with the degree of Doctor of Science Honoris Causa from the University of Colombo. During the latter part of his life, he had to restrict his activity due to his ill health. He passed away peacefully in 31st of March 1981. His family is here. I'm very thankful for them who come in to visit look this oration. And And I start this oration in his name. We all know babies are not made in heaven. Every mother wishes to have a brilliant, healthy child. In the meantime, every crying baby does not necessarily mean that the baby is perfect in future to come. There are so many adverse events that can come during the antenatal period, intrapartum period, and immediate neonatal period to the baby, and they are very complex arrangements. And there, by nature, there are mechanisms to prevent any adverse events, wonderful adaptation in the body to counter the insult that is experienced by the fetus. Today, I'm going to unveil the truths of evolving paradigms of fetal hypoxia. My presentation will be based widely on my own reviews, detailed experience and research that I gained in University of Nottingham during my postgraduate training and thereafter, and based on an immediate review written under the same heading at the research gate. Fetal environment and hypoxia. Fetus in intrauterine environment is similar to a deep sea diver in a scuba gear, connected to a tank of oxygen supply via a duct. Fetus in similarity to the diver who is inside in the scuba gear, infused with oxygen and nutrients via an umbilical cord, connected to the maternal placenta. The availability of the oxygen to the fetus is limited by different paths it's taken, and oxygen delivery from atmosphere to fetus is facilitated by numerous physiological changes in pregnancy, operating at maternal respiratory system, maternal cardiovascular system, and there are unique adaptations in the fetal cardiovascular system which directing the mix but more oxygenated blood to the vital organs via shunts. In certain adverse situations, mostly originating at the level of the placenta and the cord, certain maternal hemopoietic and cardiovascular disorders, there is a reduction in the desired oxygen supply to the fetus. This would lead to relative or absolute reduction in the fetal oxygenation, and this is termed fetal hypoxia and fetal hypoxemia. So when you call fetal hypoxia, when the fetal body is deprived of adequate oxygen supply at the tissue level, and fetal hypoxemia is due to abnormally low concentration of oxygen in the blood. As we all know, there are wonderful maternal adaptations taking place in the body. Pregnancy operating at maternal respiratory system, fetal cardiovascular system, directing mixed blood, oxygenated blood to the vital organs via shunts. In normal fetal physiology, there is no redistribution of the blood flow. Hence, each organ and structure receives the correct quota of blood. So, hypoxemia with low oxygen concentration in the blood could be part and parcel of sometimes physiological process like during labor, and low oxygen concentrations are very well handled by the fetal hemoglobin levels, shunts, fetal hemoglobin levels and the dissociations. And not only that, within the placental interface there is a double bow effect in operation which will all maximizes the oxygen delivery at low oxygen partial pressures. Despite that hypoxia occurs, it could be acute hypoxia, subacute hypoxia, or gradually evolving hypoxia, or chronic hypoxia we all know and we deal with. So acute hypoxia is one of the commonest obstetric emergencies that we deal during the labor antepartum period. Compared to chronic fetal hypoxia, the behavior, tone, amount of lico is not useful in the assessment of this condition. The CTG remains to be the best and most sensitive and specific test in acute fetal hypoxia, with limited place for intermittent Doppler auscultation and Pinard auscultation. Acute fetal hypoxia could result in cord prolapse, uterine rupture, abruption, or uterine hyperstimulation, and this is a picture of a uterine rupture. What really happens is fetal hypoxemia causes activation of the carotid aortic bodies, and then autonomic and neuroendocrine response, increased blood pressure, redistribution of the combined ventricular output, which will defend the oxygen delivery to vital organs like fetal brain and the heart. Taking a little further, this is what really happens. You have afferents and the efferents. Afferents come from the carotid receptors to the vasomotor center and the cardioinhibitor center, and the efferents through the vagus and the sympathetic chain. And not only that, these impulses act on the brain, and there are neuroendocrine vasoconstrictor responses also taking place. Management of acute hypoxia, that you all know, depends on the reversibility of its causes. Reversible fetal hypoxia due to cord prolapse, uterine rupture, placental abruption needs immediate delivery. Cord compression, maternal hypotension, hyperstimulation can be reversed by appropriate intervention using terbutaline, stopping syntocinon, positioning of the patient. Then hydration, left lateral positioning, and maternal oxygen supplementation will reduce the incidence of and severity of fetal hypoxia. Subacute fetal hypoxia is also something that we experience day to day. Fetus does not get enough time to replenish the stores and ends in leading to fetal hypoxia. Generally occurs due to overuse of oxytocics and increased maternal force to push down the bear down the baby. Subacute hypoxia generally occurs during late stage or first stage or second stage of the labor. CTG shows exaggerated baseline variability, generally well managed conservatively with strict observation to rule out profound fetal hypoxia. Assisted vaginal delivery using vacuum or forceps may be the first choice if the baby is in the second stage. This is a new concept, new thinking, and we discuss commonly about this. That is gradually evolving hypoxia. It's the most common type of hypoxia which potentially dangerous. Compared to all what I have said, it is dangerous because it comes like a normal CTG, and then within a short period it becomes bad, and another flicker of time the fetus is dead. So most probably it's missed and hypoxia which is developed gradually, leaving the fetus to adapt to compensatory mechanisms. The scenario is commonly seen in well-grown fetuses with normal reactive CTGs with normal variability. Acceleration is present with no decelerations. So this is what really happens. Gradually evolving fetal hypoxia lead to release of fetal catecholamines, result in vasoconstriction of the skin, muscle, bone, liver, lead to circulatory diversion and redistribution of the blood to fetal brain and heart. Further cerebral hypoxia, further reduction in the oxygen supply to the brain will lead to reduction in the baseline variability like you've seen in this case. And if this is continued, further hypoxia will decompensate the heart, and further reduction in the blood flow will set up a profound ischemia to the heart, and heart rate leading to drop, heart rate in a step ladder pattern like seen in this, and which is called step ladder to death. And there is absolutely no place in these patients and these babies for fetal scalp sampling. If you detect at this stage, it's best you deliver by cesarean or by assisted vaginal delivery. So this is a current concept and current thinking, and we miss this part because we talk about acute and chronic hypoxia, and this is something that we commonly encounter, and this is what really kills the fetuses. Managing of gradually evolving hypoxia is to be reversed at the level of the redistribution. Progression could lead to long-term neurological problems. Even if the baby cries, there could be residual damage to the baby which will end up in autism, neurological behavior, and chronic psychiatric disorders. It is important to monitor the fetus by CTG for increased baseline heart rate and reduction of the baseline variability. So this is the combination. Increased baseline with reduction in the variability is the first sign. So it's benefited at this stage with assisted delivery, and if the fetus is the first stage, someone should consider emergency cesarean section. Chronic hypoxia that we commonly encounter in the antenatal period, nearly 90% responsible for long-term neurological disability and abnormal neurobehavior. So this is something that we need to say before the delivery of the baby, and caused by genetic factors, fetal aneuploidy, fetal viral infection, and certain autosomal recessive disorders, maternally caused by placenta insufficiency, hypertensive disorders in pregnancy, acquired and congenital thrombophilias, and maternal congenital disorders of long-term maternal medical disorders. There is prolonged period of inadequate oxygen and nutrient supply to the fetus, leading to compensatory mechanism of readjustment and redistribution. Antenatal hypoxia causing reduced fetal reserve, hence increases the susceptibility of the hypoxic injury, especially during intrapartum period. The fetus is usually demonstrating reduced LICO, reduced growth potential with lower abdominal circumference, reduced subcutaneous fat, and low estimated fetal weight, and increased Doppler indices. Can we predict antenatally chronic hypoxia? Yeah. People have devised many methods. Use of the biophysical profile, what we do in our common clinical practices, and it's a very objective test, and then it has to be interpreted along with the clinical features and clinical examination and all that. And what we do is assess the fetal tone, gross body movement, fetal breathing, fetal heart rate using a CTG, and then qualitative assessment of the amniotic fluid index. And there are two types of biophysical profile, that is modified biophysical profile and conventional biophysical profile. Both carries no merit over each other, but both are useful, but not as much as what we think. So it's the choice of the obstetrician selecting in this particular test, taking a long time, but there will be many other tests who will give better sensitivities and positive predictive values, which we'll come across in few next slides. I'm personally biased to Doppler velocities because I can't wait long and I need to assess the baby within a short period. So Doppler flow velocities are part of well-trusted routine antenatal fetal surveillance during the past 2 decades. It provides insight into uteroplacental and fetal arterial and venous circulation non-invasively, and Doppler examination has a key role in detection in hypoxic fetus, since abnormal blood flow patterns can be demonstrated well before the clinical manifestation of fetal disorder. In randomized controlled trials, it has been shown that Doppler has the potential to reduce the perinatal deaths by 66%, and Doppler velocimetry will facilitate the judgment in the diagnosing, monitoring, and fetal well-being during pregnancy and labor too. And it's also helps the obstetrician to decide about the timing of the delivery. So different velocities, first we do the umbilical artery, and then umbilical artery becoming abnormal, then you go for middle cerebral artery, and if that is also abnormal, one can go for ductus venosus, and no Doppler beyond this. You need to deliver the baby if the ductus venosus showing reversal waves and abnormal waves. So ultimatum is ductus venosus, so umbilical, middle cerebral, and ductus venosus is the sequelae. We tried many methods using the functional MRI, conventional MRI, and this was my first research done in Nottingham, and we were the first to explore the use of functional MRI using the blood oxygen level dependent Bold effect, and it was quite safe during pregnancy. MRI is very safe in pregnancy, and we had published many articles. First we studied the functional ability using various stimuli, visual, acoustic, and vibro, all the stimulations, and then mapped the brain, and we studied the pattern of the blood flow in the brain, And then our second plan is to use it for abnormal hypoxic fetuses, which they do not demonstrate this kind of activity in the brain. But the problem is the expensive and availability of the MRI makes it still at a research level for special patients. I know our Major General Sanjeeva is very well conversant with these MRIs. So this was done without the involvement of the radiologist in Nottingham. I was on the obstetrician and with the Department of Physics. We didn't stop there, and I was exploring many other methods where we can detect the antenatal fetal hypoxia. Always my mind was going towards a non-invasive techniques like ultrasound. So we published this prediction of future neurological outcome abnormality based on fetal neurobehavior and the role of the obstetrician in identifying and preventing such occurrences. Again, we were talking about hypoxia, how we did diagnose the hypoxia using a 4D ultrasound scan. I said about the ultrasound used in Doppler, and this is another way. If you have the 4D machine, use the 4D machine to look at these movements. First trimester, general fetal movements, startling response, stretching, isolated arm and leg movement, head rotation, anteflexion and retroflexion, and second trimester, mouthing, yawning, tongue expulsion, grimacing, swallowing, hand, head, eye, face, mule. In other words, if you have these movements in the baby, that baby seems to be non-hypoxic. In the same time, the baby shows hypotonic movements, high amplitude, high speed in upper extremities, emerging abruptly kind of movements, burst post patterns, no change in fetal expression, facial expressions, all that indicates that the baby is hypoxic. So different ways of assessing the babies. You can see the different movements of the baby, and all, mind you, all these babies were normal, and I don't have 4D pictures of abnormal fetus. So you can see all what I have mentioned, we can check in a checklist, right? Hand, eye movement, grimaces, facial expression, yawning, mouthing, and all those movements. So this is a very, very handy, non-invasive, very simple test. Only thing you need to know about how we do a 4D ultrasound scan. Right. So coming back to assessment of the baby after the delivery, postnatal assessment, we have our conventional Apgar, Virginia Apgar device in 1953, based on the heart rate, respiration, muscle tone, reflex, irritability, and color of the baby, and then direct action. I must warn my juniors doing the fetal scalp blood sampling, umbilical artery. It's a legal tool currently. And then Saranat and Saranat has given a more predictive value based on HIE scoring system, grade 1, 2, 3, which is more future neurologically predictive. So many ways of assessing until Hossein and Dalaili and the colleagues have shown the results of combined Apgar, gas analysis, fetal ultrasound of the brain has the best sensitive. So you don't do one test, you do all 3 tests and document it. That really reflects the future neurological outcome in the combined test. And this is the study comparison of 4 proposed Apgar scoring systems in the assessment of birth asphyxia, and you can see the sensitivity and specificity was very high, ranging up to 97 to 99%. So the conclusion of this slide is that you do all, if you have a distressed baby, do the Apgar, do the blood analysis, do the HIE scoring system, do the fetal brain ultrasound scan. So that all will complete your postnatal assessment. And current paradigms of the hypoxia come into a different aspect. When the placenta is ischemic, Charles and Wood and Maureen Keller, in 2020 studies, they have found that maternal colonization of microorganisms goes through the hypoxic placenta. Compared to normal placenta, they do not allow, but hypoxic placenta allows the microbial transfer, and which will cause the sepsis of the baby. This would explain microbial transfer through the placenta that turns and colonizes and infects the fetus, explain some rise in CRP levels even in the absence of fetal septic focus, right? So it has been documented and very well established fact now. So ladies and gentlemen, coming back to the summary of the hypoxia. So you see a hypoxia, you have acute and delayed responses, all acute cardiovascular neuroendocrine, and delayed could be, like I said, microbiological and neuroendocrine, which has the burden on short-term survivals and long-term programming. And these are the acute changes which I have already mentioned. Hypoxia activating the vasomotor center and cardioinhibitor center through their afferents and efferents, and ultimately redistribution, increase in blood pressure, defending the oxygen delivery, and then chronic hypoxia leading to long-term sequelae, neurological deficit observed following the relative or absolute hypoxia depend upon the extent of the insult. You get the oxygen from the environment. Sometimes the placenta may not be really problematic, but the environment is hypoxic, right? And then the placental hypoxia all will act on the depends upon the extent of the insult, and this is also widely influenced by endocrine axis dysfunction and oxidative stress and abnormal epigenetic modification. And it's mainly influenced, the hypoxic injury is mainly influenced by influence upon the time lapse before the normal breathing is restored and the CNS maturity of the fetus. A severe asphyxia has been linked to cerebral palsy, mental retardation, and epilepsy, while mild to moderate asphyxia has been associated with cognitive and behavioral alterations such as hyperactivity, autism, that we talk about today. We know that autism has a hypoxic origin. And attention deficit in children and adolescents, low intelligent IQ scores, schizophrenia, and development of psychological disorders. So not only that, ejaculatory disorders, anxiety, depression, all are part and parcel of chronic hypoxia of the fetus. So summarizing what I have said, the compensatory mechanism to hypoxia clearly reflects the results of the investigation like CTG. CTG remains to be the best choice in acute hypoxia. Biophysical profile is to be considered carefully along with the clinical history. Doppler assessment is very useful in timing the delivery, intervention, and follow-up, and 4D ultrasound will give promising results in the assessment of chronic fetal hypoxia. Combined assessment of the neonate truly predicts the long-term neurological outcome. Both severe and moderate hypoxia could lead to long-term neurological problems and long-term sequelae. And this is where we start the work, and this is my wife Gayani, who is here with us today, and our research team, Rachel, Gayani, and my two sons who are currently postgraduate and undergraduate in overseas, and myself, and Jonathan Fulford. Jonathan now currently he is the professor in Exeter. Rachel remains to be the professor of physics in Nottingham. My mentor, two mentors you can see in this, Professor Phil Baker, introduced by my other mentor, Professor D.A Ranasinghe. I'm mostly grateful to him. He made me a very clever, skillful person. So with the blessing of all these people, I am here today giving you this lecture, and I would like to thank that this presentation is in tribute to Professor D.A Ranasinghe. I wish to thank the family who is here today. I mind thanks to you, sir, Honorable Prime Minister, and Madam Shiranti Rajapaksa, Mother of our hearts, and Honorable Minister Dr. Kehelia Ramukwala, very dynamic, well-spoken, and we like his fashion. And our most helpful hands, Major General Dr. Sanjeev Munisinghe. He is a very skilled radiologist, and now he is the secretary. And Dr. Asela Gunawardena was my director when I started at my first VOG job at Horana. So I'm very happy that all are here. And my teacher, D.A Ranasinghe, and Dr. Pradeep Silva and Sanat Nanarol, my inseparable companions in the field of obstetrics and gynecology. And I wish to also thank the patron, Secretary Dr. Mathot, and all the members of the council, and my Vice Chancellor, Dean, both are here today. I'm very proud that your presence to see my oration. And my department colleagues are here. They are looking after me, my work when I'm not there. And Vishal, Harshini and Piyumi and SLCOG staff, and my CEO and my staff at NRC. I have so many places to work, so they all are here. And I thank Professor Lal Chandrasena, representing the Navaloka, and all my colleagues who are here today to witness this oration. I thank you very much.